welcome everybody again to another neonatal lectures. This time, I'm really excited to introduce Professor Stuart Hooper, who recently stepped down as the director of the Ritchie Center, where he did tons of research looking at fetal and neonatal physiology, particularly neonatal lung development, but also, of course, lung circulation and interactions between heart and the lung, and how gas exchange can be sort of followed to different forms of respiratory support or circulatory support. Today, he's going to present us some work which he did on wet lung. And I don't know about you, but that number of admissions of wet lung to the clinicians has increased significantly, I feel, particularly in the high care situation, with providing more respiratory support. And for a clinician, it might be a relatively straightforward kind of disease, but what is it? And what causes it? So I hope Stuart will tell us today in way more detail of how we can think about this disease. So Stuart, over to you.
Thanks, Kurt. You're a man after my own heart. I'm one of those guys who before you can start thinking about how to treat something, you really got to understand how on earth it works. And so what I hope to do today is to give you sort of the latest interpretation of how we think wet lung is causing respiratory distress in near-term infants. But unfortunately, I know many of you will cringe when I say, well, I've got to take you back and talk a little bit about fetal physiology 303, because it's actually not well taught to neonatologists in general. And so I often get questions about it, and particularly this point about, how much liquid is in the airways before birth. And there's lots and lots of data on this. And we've known for 50 years that the actual lung the airways are filled with liquid, and that volume of liquid is greater than the volume that you would see at FRC after birth. And here's a graph here. This is from a fetal sheet that was done almost 30 years ago. And what it shows you is that the volume, particularly in late gestation, is quite substantial, up 35 to 40 mils per kilogram, which is greater than what you would expect to see after birth. I'm often asked, why do you need such a high volume? Well, this high volume is really, really important. We know that it's critical for lung growth. You only have to reduce the volume by a small degree down to basically what you would see after birth, and you end up with very severe lung hyperplasia. So this liquid, it maintains the lung like an inflated balloon, and it provides a stretch stimulus which the lung needs for it to grow. But the problem is, you end up with all of this liquid in the airways at the time of birth. So how is that liquid cleared? Well, there are a number of mechanisms, and the first mechanism I want to introduce to you is one that is often ridiculed, actually. People confused it with a vaginal squeeze, so where the head and the chest in particular is passing through the birth canal, which sort of squeezes the chest. That's not what this is about. This is about probably before that point, where the head is engaged with the cervix, the uterus is contracting down to try and push the fetus out through the cervix and vagina. It causes an exaggerate, particularly after the membranes have ruptured, it causes this exaggerated dorsoventral flexion, and as a result of that, liquid tends to leave the infant via the nose and mouth. I would argue that this is probably one of the most important mechanisms for airway liquid clearance, particularly before birth. And my reasons for that will become clear in just a moment. The mechanism which you guys would all be very familiar with and think that, well, this is the primary mechanism for airway liquid clearance, is probably what you've been taught, and it's what's in a lot of the textbooks. I would argue that actually it's the least important mechanism for airway liquid clearance. And indeed, again, getting down to that theme, well, how does it work? Whenever you usually ask somebody this, they said, oh, yeah, I know how this works. It's sodium reabsorption. And you ask them, well, how does that work? Oh, I don't know. Sodium gets reabsorbed. Well, the theory goes like this. You have an epithelium, which is, I've animated here, it's in yellow, that separates the lung lumen from the interstitium. So these are the epithelial cells. So during the stress of labor, adrenaline is thought to bind to beta receptors on the basolateral surface of these epithelial cells. They stimulate an increase in intracellular cyclic AMP, which then act on these ENaC channels that everybody talks about, which open and allow sodium to enter the cell. Sodium potassium ATPase, again located on the basolateral surface of the cell, very sensitive to intracellular sodium ion concentrations. So as soon as they detect sodium levels going up, they pump the sodium out for the exchange to potassium ions. The net movement of sodium out of the lung into the interstitium creates an osmotic gradient for the movement of water. So that's the theory of how it works. And there's probably no doubt that it does work. But the problem is that it only occurs very late in gestation. So preterm infants can't clear their airways with this liquid. And it's very slow. So maximum clearance rates, even if you use pharmacological levels of adrenaline, are only around about 10 mils per kilogram per hour. And we'll see in a moment, there are other mechanisms that are much quicker. And this brings me on to the third one, which is one we really stumbled across, or re-stumbled across, I should say. People have described it previously when we started to do phase contrast X-ray imaging. And what is that? Well, it's a technique of using X-rays to see air as it enters the lung at birth. And what I have for you on the left is an image of a rabbit pup. So these are in rabbits with a liquid-filled airway. And so because it's liquid-filled, there's no phase contrast, and so you don't see the lungs. On the right here, what you're looking at is an aerated lung. So it's a neonatal rabbit pup, about an hour old. It has a well-aerated lung, and now we can clearly see the lungs. We can see the trachea, the major bronchi, and if we blow up a region down here, we can actually have the power, the resolution power, to see single alveoli in projection here. So using this technique, you can also see bubbles here, they're in the stomach. But using this technique, we can watch as the lung goes from here to see how it aerates. At the same time, we usually have them in a what's called a plethysmograph, which is simply just a contraption to measure air gas volumes. And what you're looking at here is the plethysmograph recording. So this is in a spontaneously breathing rabbit pup, right from birth. There's probably taken a breath before this, but here's our first recorded breath. The air goes in, air goes in, then comes out, and what's left behind is the FRC. As you can see, between the breaths, the FRC decreases a little bit. That means a little bit more liquid is coming back into the lungs. But bang, next breath, it clears that liquid again. And subsequently, with each breath, we get more and more airway liquid clearance. So within 35 seconds, okay, you've basically generated an FRC of around about 17 mils per kilogram in this instance. We can take an image before the breath, and if we take one during the breath, it's just a blur. So we look at the images immediately after the breath, and you can see how rapid the aeration is. And if you look up here, adrenaline clears at a maximum rate of 10 mils per kilogram per hour. When you do the maths here, it's more like 32 liters per kilogram per hour. So this rate of airway liquid clearance explains how newborns, they can aerate their lungs and initiate gas exchange within a few seconds of birth. It may only take 5 breaths, for instance, 6 in this case, before they've generated a stable FRC and can commence gas exchange. So what's going on here? Again, this is a very simplistic diagram of an airway surrounded by lung tissue. And simply what's happening is that during the inspiration, you're generating a subatmospheric or a large subatmospheric pressure in the tissue, which then creates a pressure gradient between the tissue and the surrounding airways. As a result of that, driven by this pressure gradient, liquid moves out of the airways into the tissue. So with each subsequent breath, more liquid exits the airways and enters the tissue. So with each subsequent breath, you're getting more air into the lungs, and this liquid is then, as I said, moving into the tissue. So there's why I just taking you back to the point why I think mechanism 1 is the most important. When you look at these two mechanisms, okay, the sodium, whether it's sodium reabsorption or whether it's the clearance due to inspiration, the transpulmonary pressure generated by inspiration, in both of these mechanisms, the liquid has to go into the tissue. So whatever liquid which is within the airways has to go into the tissue if you're born, when you're born with liquid in your airways, and you will be born with liquid in your airways. Alternatively, if you actually are born vaginally, you pass through this mechanism, the liquid actually leaves the lungs. It doesn't have to go into the lung tissue. And as a result of that, so probably the reason why, in the absence of labour and vaginal birth, so in the absence of this mechanism, all liquid in the airways must be cleared via mechanisms 2 or 3, which means that all of the liquid actually has to go into the tissue. And that causes pulmonary edema after birth. And I think this is where the problem lies. And the difference why there is less respiratory problems in infants delivered by following labour and vaginal birth versus those that miss out, maybe by elective caesarean section, so there's no labour and no vaginal birth, and are delivered by that mechanism. So in its essence, if you're delivered by caesarean section with labour, potentially you have these large volumes of liquid in your airways, and all of this liquid has to be absorbed into the tissue. However, if you're born vaginally and you go through that process where you lose a lot of liquid via the nose and mouth, you may end up with only 10 mils per kilogram of liquid that you have to reabsorb into your lung tissue after birth. So this brings us to the point again where, okay, let's now think about, well, what is the problem of having too much liquid? Now, in that tissue space after birth. And, you know, theoretical, well, it's not even theoretical, that's actually, people have measured it. But because the liquid is going into a finite space, the pressure has to go up. And believe it or not, somebody has measured the interstitial tissue pressure in the lung after birth and shown that there's a very time sensitive change or time-related change in the tissue pressure after birth. This increase in tissue pressure is due to the liquid going into the tissue, but then as the liquid is cleared over the subsequent 4 hours, it's cleared by the lymphatics and blood vessels, the pressure becomes negative, and it stays negative throughout the remainder of our lives. In addition, because you've got liquid going into the lung tissue, and you've got air that's coming in to replace that liquid, then the chest wall, because the liquid hasn't left the chest wall has to expand. And just to give you some idea what that looks like, here in this image, we have, it's the same rabbit pup that's been imaged, but it's been imaged before. So one frame before lung aeration, and in this instance, the ribs are, the image is reversed and the ribs are coloured in white. And then an image of the same animal after the lung has aerated. And in this case, the images are seen in black. And you can see how much the chest wall has expanded to accommodate this incoming air, as well as to accommodate the liquid that was in the tissue and has now moved into the airspace. So the issues that I think are most relevant to why some babies have difficulty after birth, whereas others don't, is basically how much liquid has to go into the lung tissue. So if you're born vaginally after a long labour, the baby's probably lost a lot of lung liquid via the nose and mouth. And so the volume of liquid that has to be absorbed into lung tissue is a lot less. And so the increase in pressure is going to be a lot less. Whereas infants delivered by cesarean section and labour are going to have larger volumes of liquid in the airway, therefore larger volumes of liquid in the tissue, or that's entering the tissue. And we're pretty certain that this is the underlying cause of transient tachypnea of the newborn. And to explain how this liquid in the tissue can affect respiratory function after birth, again, I apologise, but I do have to take you back to a little and talk a little bit about respiratory physiology 202 and the pressure within the different thoracic compartments. But to be fair, much of, or some of what I'm going to tell you is not in the textbooks, and it's certainly not taught to second year students. And so if we think of the different compartments of the respiratory system, we can see that in its most simplistic sense, the lung is basically airways, which are air-filled, that are embedded in tissue, lung tissue. So there's two compartments. There's the tissue compartment and the airways. But on top of that, we have capillaries and blood vessels. So we're only going to talk about them in terms of capillaries. And we also have the lymphatics, and they all play obviously really important roles, and particularly the lymphatics play a very important role in clearing the liquid from the tissue. Now, the lung itself is surrounded by a membrane called the visceral pleura. And this membrane, and it's important to remember here, this membrane is actually impermeable to liquid and to gas. And that's the reason why you often see, during a pneumothorax, you'll see what we call these subpleural blebs. Now, the lungs then sit in the chest, and the chest wall is lined by a membrane called the parietal pleura. And the space between the lung and the chest wall is separated by the intrapleural space, which is liquid filled. So what happens with the lung wants to collapse due to its largely due to surface tension within the lung, but also due to its own recoil properties. And that then drags the chest wall in a little bit. And so at equilibrium, the chest wall is counterbalanced. The chest wall wants to spring out, and that is exactly counterbalanced by the lung wanting to collapse. Now, of course, they don't, because the intrapleural space is filled with liquid, which is inexpandable and incompressible. And so the two are in balance. Then, of course, because of that, what that does is generate a subatmospheric pressure within the intrapleural space, so we all know about that. But what we're often not told, or we're not told at all, is that the pressure within the tissue is also subatmospheric. And at the top of the lung is actually more subatmospheric than it is in the intrapleural space. And this, and we're often not told about this, plays a very important role in lung function. We'll talk about this in a little bit. But if oh, yeah, well, actually, sorry, I will talk about it now. I thought I was going to move on to something else. The reason why this is really important is because if a little bit of liquid gets into the airways, because there is a hydrostatic pressure gradient for the liquid to move into the airways and out of the airways into the tissue, it acts sort of like a vacuum cleaner. And it rapidly allows liquid to move out of the airways and into the tissue. It also helps stabilize the airways, because the airways, you have a 0 atmospheric pressure here, and having a subatmospheric pressure in the tissue helps to keep the alveoli open. They also have connective tissue that projects in from the visceral pleura, but they're mainly involved in lung expansion during inspiration. So at rest, these subatmospheric pressures in the tissue play a really important in keeping the airways open. Not only that, they play an important role because there's going to be a positive pressure in both the capillaries and in the lymphatics. It also helps to keep those vessels open as well. Now, so this recall of the lung plays a really important role in maintaining those pressure gradients. So if you have a pneumothorax, air comes in and allowing air into this space here, air is expandable. And so as a result of that, the lung collapses. Now, I know a lot of people sort of overlook how important this sort of intrapleural pressure is in maintaining lung expansion. And I actually have a video here to show you, or to give you an example of how important it is. And this is of a sheep. And what you're looking at is at the diaphragm muscle. You can see here. So here's the costal muscle here, vertebrals down the bottom. Here's the ligament. And underneath that, you can see the lung, and it's very pink in color. And what will happen, so we're looking at from the abdominal side of the diaphragm. So at the moment, the chest is still sealed. So here's the liver here that you're looking at. So as I start the video, knife goes in to put a hole in the diaphragm, and you can see how the lung collapses and how the diaphragm springs open. So the experimenter here was a bit cavalier. He punctured the lungs, but now they're inflating the lungs and allowing them to deflate, inflating them again, and deflating them. So you can see it's very clear. I'll just play it again. It's very clear how important the chest wall is in maintaining lung volumes or lung expansion at rest. And we shouldn't be over or underestimating how important it is, because otherwise this is how much the lungs would collapse at end expiration without the influence of the chest wall. So what happens at birth? Well, as we've already mentioned, the liquid goes out of the airways into the tissue, which increases the pressure gradient, the interstitial tissue pressure, because it's going into a fixed compartment. Normally, that is cleared by the lymphatics. As I've said, it can't be cleared across the visceral pleura because that is impermeable to liquid. Any liquid that's in the interstitial place is actually regulated by clearance movement across the parietal pleura rather than across the visceral pleura. the only other way that liquid can be cleared from the tissue is going back into the air spaces, or into the blood vessels as well. So if you have the situation where you have lots of liquid, all of this liquid then has to go into the tissue. Well, then you have the situation, well, first off, as I've already showed, is the chest wall has to expand and the lung expands. Now, believe it or not, if you try and get a measure of what sort of pressures we're talking about, somebody's actually measured the compliance of lung tissue. And this is in an adult, so it's probably not really that relevant or to a newborn, but it's the only information that we have. And what they've shown is that tissue pressure increases by 1 centimetre of water for every 0.4 mil increase in liquid in a 100-gram lung. So if we do the maths in a newborn that's delivered by cesarean section without labour, that may have 25 to 32 mils per kilogram in their airways at birth, 3 kilo baby, 90-gram lung, 70, 90 mils, so going into the tissue, that equates to a pressure of about 175 to 225 centimeters of water. So we're talking about very, very large pressures, but that's unlikely to happen. But likewise, as I said, we really don't know, and particularly the influence, but these high pressures will drive liquid back into the airways. How does nature cope with it? Well, we don't really, the reason why we expect that there's nowhere near this sort of pressure rise in an infant. And it's largely because the newborn chest wall is highly compliant. And so it effectively expands to accommodate both the liquid and the incoming air. But it has to have a limit. And presumably, when you have a lot of liquid in the airways that has to be accommodated in the tissue, it's more than likely that this limit is breached. And so that's when difficulties start. So, as I said, when you have this liquid in the airways, the other issue is that not only does the liquid potentially go back into the airways, because of the high pressure, it actually also can cause the airways to collapse, but it also can cause the lymphatics and the blood vessels to collapse. Now, if they all collapse and you have all of this liquid in the tissue, well, how's the liquid going to get out? Because it's unlikely to go out via the lymphatics and via the blood vessels because they're basically collapsing, and it can't get out across the visceral pleura. So I've talked, you might think, oh yeah, look, this is an interesting theory. Does it have any relevance to the real world? And yeah, it does. Now, we know that pulmonary edema, so this is quite old physiology. So a lot of this physiology goes back to the 60s and 70s, 1960s and 70s. We know that pulmonary edema, by stimulating J receptors, actually causes tachypnea. It also, because the liquid will be filling the airways, it reduces the surface area for gas exchange, so it'll be causing hypoxia. It will be reducing FRC and presumably triggering grunting. Reduces respiratory tissue compliance because you've expanded it. Reduces the respiratory reserve volume, okay, because you've expanded the lung, flattened the diaphragm. And because you're increased the pressure and reduced the transmural pressure across the capillary wall, you'll also be increasing pulmonary vascular resistance, which reduces pulmonary blood flow. So the question is, that will remind you guys of a lot of symptoms that you see clinically. And, can we induce this experimentally? And as I've already showed you, yes, elevated liquid does cause the expansion of the chest wall and flattening of the diaphragm. What I have here is a an example of where we've just got, these are near-term rabbits that are on the left, there is a control. And what we're doing is you're just looking at a clip here at the end. We give them a sustained inflation. And at the end of the sustained inflation, we go into intermittent positive pressure ventilation. And so you're looking at what happens to the lung as it transitions from a sustained inflation to just intermittent positive pressure ventilation. So let's look what happens if it has too much liquid in the airways. You can see, well, it aerates okay. But as soon as it finished the sustained inflation, you swap over to intermittent positive pressure ventilation. And you can see, as we predicted, well, the airways are refilling with liquid. You can see the bubbles going up and down here, up and down the airways. Okay. So we've done a lot of work here. These are all been in ventilated animals. And we can see, well, what is the effect on lung function? We can see that the chest wall area is increased, as I mentioned, so the expansion of the chest wall, which causes flattening of the diaphragm, and that's measured as an increase in the radius of curvature of the diaphragm. So basically what that means is that it's describing an arc with a much, much greater radius. So because it's flattened. Reduces functional residual capacity, decreases lung compliance, and increases the requirement for supplemental oxygen. So you can see that having a elevated liquid, and so the elevated liquid here is around about 30, what we estimate it to be around about 30 mils per kilo. So we can also, this is just in another instance where you can produce elevated liquid in one lung and then look at the effect on lung aeration. You can see even in the same animal here, here we have elevated liquid in the right lung as opposed to the left lung. You can see the left lung is well aerated, whereas the right lung is poorly aerated, largely, and this is measured at FRC, largely due to liquid re-entering the airways at FRC. So what effect does it have on pulmonary blood flow? Well, it actually reduces pulmonary blood flow. So if you look at the effect here of adding too much liquid, we have a reduced pulmonary blood flow response to lung aeration compared to controls. So that was in ventilated animals. And in that case, so we're looking at lung function. We can get good measures of lung function, but we're not actually assessing what happens to respiratory control. What happens to breathing rates, what happens to grunting and expiratory braking, all of those features that you would be commonly used to seeing in infants that are developing, or term infants developing respiratory distress. So we've generated a couple of models, animal models, looking at it in both lambs and rabbits. And you can see here that this is in lambs, in spontaneously breathing, so control lambs here, and the elevated liquid lambs. This is a measurement of the arterial-alveolar difference in oxygen. So this is giving us an idea of the gas exchange or the oxygen exchange potential of the lung. And we can see that with a high, because there's a high difference, that means that the lung is not performing very well, whereas a low difference means that it is. And this is basically means that the required FiO2 these lambs needed to sustain reasonable oxygenation was much higher out to the first 4 hours after birth. So what about some of the other parameters we see? So particularly expiratory braking. This is very complex. type of analysis that you have to do, because we need to take into account, you know, the lamb's breathing rates, breaking, are they active and therefore breathing more because they're active, or are they sleeping? And what you can see is that initially they're certainly doing a lot more. This is mainly glottic breaking. So this is grunting. Were they technique? They weren't initially, but they are after the first 30 minutes. But again, as I said, this is complicated. The control lamb started to become a bit more technique, or what we define as technique, but that's because they were in a sling and wanted to go for a run in the sling trolleys, because they're all conscious lambs. And so that's artificially inflated those breathing rates here. But if you look at a very interesting feature is the diaphragmatic breaking that we observed, is that these lambs started to develop quite substantial diaphragmatic breaking. So this is a post-inspiratory diaphragmatic contraction that occurs. And when we broke the data up and looked at the males versus the females, we can see that the males do a lot worse. They are less active than the females and significantly less than the controls. They were less technique than the females, tended to be more technique. But this is largely because the males were the ones who were showing this post-inspiratory diaphragmatic contractions that are, they're actually slowing the respiratory rate as a result. So we then, to try and get our heads around precisely what's going on, our PhD student in India, who was doing all of this work, India Davies, developed what you call the morbidity score. And that was constituted with a number of different adverse parameters. So how much respiratory support, this is mainly CPAP, and their arterial pH, the FO2 requirement, breathing rate, presence or absence of glottic expiratory breaking and diaphragmatic expiratory breaking, expiratory pauses, size, and apnea. And as you can see here, that the males, both males and females are affected, but the males are affected to a greater degree than what the females are. So elevated liquid not only alters respiratory function, but it also changes the respiratory patterns that are generated that drive respiration. And that is likely to be very complex, because there's blood gas and chemoreceptive mechanisms that are feeding in there, as well as other receptors that are feeding in from sensory receptors feeding in from the lung itself. For instance, the J receptors that I mentioned. So we were using here 30 mils per kilogram, and I just wanted to put this a little bit back into context, because during COVID, so in adults, during the initial infection phase, when the respiratory problems was largely due to pulmonary edema. The pulmonary edema that was lethal in adults was around about 15 mils per kilo. So that's substantially less than what newborns easily deal with. So we're talking about 30 mils per kilogram, but they'll easily deal with 20 mils per kilogram without much trouble at all. But it's lethal in adults, and we think this is largely due to the chest wall. And the stiffness of the chest walls, because and of course in the newborn they have a very compliant chest wall, whereas the adults have a relatively stiff chest wall, which gets stiffer as you get older. So what's the solution? Well, there's a number of solutions here that you can try, and we've got one. One is to reduce airway liquid volumes at cesarean section delivery, and this is called the KCF maneuver, or knees to chest flexion. We do have a trial underway at the moment, looking at this. There's already been a feasibility study, and I think if we're not careful, people will start using this and will then won't be able to undertake a proper trial or large trial to examine the benefits of doing this. But it's not going to be the fix all, because a lot of the infants who are delivered will actually take a breath before you can do any of these sorts of maneuvers. The idea is to do it as the head is being delivered, but the infants may take a breath and that generates an air block, which will prevent a lot of the liquid coming out. So it won't completely, I don't think it will be a complete solution. At the moment, CPAP is the current go-to therapy for this. It does keep the airways open and clear, but it increases intrathoracic pressures. Nature's solution, and of course we probably don't want to do that too much. Pressures are already quite high, intrathoracic pressures. So nature's solution is to endow the baby with a compliant chest wall so that it will easily expand. So perhaps what we could do is help the chest wall to expand by altering the extrathoracic pressure. And so we've been looking into this and comparing pressures that amount to basically what the pressures that occur, the positive pressures that occur when a baby is swaddled, versus the subatmospheric pressures and particularly a negative pressure, what effect these have. And again, we've only really just started to embark on this, but just looking at lung function, here, this is in control animals. We have when you apply a negative extrathoracic pressure of 6 centimeters of water, no pressure, or a positive pressure of 6 centimeters of water. And you can see you have quite a dramatic effect on respiratory system compliance, with the negative pressure actually greatly increasing compliance. If you then, as a result of that, they require a much lower mean airway pressure to achieve the total volumes that we're trying to achieve. On the other hand, when we look at elevated liquid, we see that while there's not much difference of applying a positive pressure, yes, applying a subatmospheric extrathoracic pressure does have a substantial benefit in terms of altering lung function in the newborn. So that's where we're at the moment, really looking into that. Just to summarize, airway liquid clearance into lung tissue causes pulmonary edema after birth. Now, that is always going to happen. So every single infant, because you cannot get rid of all of the liquid in the airways, some is going to have to be cleared into lung tissue. It just depends how much. If you're born after a long protracted labour, well, then probably not very much. But if you're born by elective cesarean section before the onset of labour, and particularly before rupture of the membranes, then it's quite likely there will be substantial volumes of liquid that need to be cleared into the tissue. And we think that simply what you're looking at with transient apnea is that there's just too much liquid, and the infant is struggling as a result of pulmonary edema. Possibly one treatment may be the knees to chest flexion during elective cesarean sections. That may reduce the risk, but as I said, I doubt it, whether it'll completely avoid it, because some infants are just too quick to take their first breath of air. But if it can be easily applied, and we need to think about ways of potentially doing this, that a negative extrathoracic pressure, which helps to expand and stabilize the chest wall, may be the best approach for treating those infants. So that's what I have for you today. So thank you very much for listening, and I'll be very, very happy to answer any questions that you may have.
All right, Stuart, this was great. Look, I do think you have explained, at least in part, why some of the babies we see with particular sort of scenarios you describe, born before the membranes were ruptured with a planned cesarean without labor, which is a known risk factor for this particular sort of maneuver. And I think the balancing act which you described between all the different pressures and different components of your chest and also the chest wall, and the importance in there was certainly something I probably didn't realize as much as that you now described. There's a couple of questions coming in, which is great. First, the question is about the mode of delivery, and we know that planned cesarean without labor is the highest risk, but is there other modes like breech vaginal?
Not that I'm aware of. I think the highest risk factor is the delivery via elective cesarean section. I mean, anything that should have breached, presumably, if they're forced into that dorsoventral flexion, then they should lose liquid. I mean, we're talking about very small pressures here. I mean, you only have to, increase pressures by 4 or 5 centimeters of water, and this is where you're increasing abdominal pressures. You do lose substantial volumes of liquid because the whole system is extremely compliant. And as even we know that oligohydramnios, for instance, where you just lose that amniotic fluid, that causes substantial loss of lung liquid. And as a result, you get quite severe lung hyperplasia.
So, and just to clarify that whole maneuver where the pressure gets water coming out of your nose and mouth, do you have to not breathe for that?
Well, whether you're asking a question that we really don't know the answer to. We suspect there'll be an air block once the baby has taken a breath, and it'll be much harder to get that liquid out, particularly without having substantial effects on the infant, which of course, obviously, you want to avoid. Do you remember back to your second year physiology, when you're doing medicine?
Oh, wow.
Doing respiratory physiology?
Yeah, you remember the one where you had to close the mouth with meconium kind of thing. There was some sort of stories for it, but no. Yeah.
No, I'm actually talking about when we were doing spirometry, just teaching basic spirometry. I mean, I used to teach the med students this, where we'd get them to stand up and we'd be looking at their, your lung function. Then they'd sit down and their lung volume would drop. Then they'd lie down and the lung volume would drop further. And then we'd put them in a fetal position and the lung volume would drop even further. So, that is the classic example of what the effect of abdominal pressure has on elevating the diaphragm and increasing thoracic pressures and reducing lung volume. I think that's the best example. Just so if people want to demonstrate it to themselves, just hook yourself up to a spirometer and you'll see that happen very substantially.
I'm going to do one more question because that's a burning question. Then I go to Andy, who has his hand up. You explained the differences, and particularly the treatment CPAP, and I introduced you, and it's my experience, and I talked to others as well. We are doing more CPAP for these babies. They get on it 4 hours later, it's all gone, and they go on the breast and they're fine. So, is it good? What are we doing?
Well, that's a good question. I think it's only in severe cases that, you might be pushing them over that sort of boundary. Because, when you are putting CPAP on, and if you've got a good seal, well, then you're pressurizing the airways and you're pressurizing the chest. So if you've got, 5 centimeters, 6 centimeters of water of CPAP on, you're going to have that. And that's then being transferred, across into the tissue as well. what effect that does, you're relying on, because the pressures here are very small, the pressure gradients, and it may be making breathing easier for the baby, but you're actually protracting out the length of time it's taking for it to dry out the lungs and to lose that liquid via the lymphatics, simply because you're, closing down and increasing that pressure gradient, which tends to cause them to collapse. This is really, I mean, it's really interesting from a point of view of what happened during COVID, because it's a very, very similar scenario where you have these, patients with amazing amounts of liquid. I don't know if you saw the CTs of the COVID patients. They had very large consolidated regions. And the thing is, it didn't resolve. And diuretics didn't work. So why didn't diuretics work? Well, I think the answer was pretty simple, was because what was happening is the liquid's trapped. And because the pressures have built up so much, all of those small vessels, the blood vessels and the lymphatics, have closed and collapsed, so the liquid can't get out. That's a theory. I actually wrote a letter to the Lancet, espousing that theory, and they said, oh, and because it was quite complex when you're looking at the pressure gradients and things, they said, oh, that's a very interesting theory. Can you cut it down to 600 words and we'll publish it in, and I said, oh, give us a break.
All right, Andy, you had your hand up.
Yeah, thanks. Love it, Stuart. Great talk. One of the things that went through my mind just listening to it, particularly in your last 5 or 10 minutes there, I mean, this really is back to the future. I mean, not only have we forgotten all the physiology that was done years ago on dogs and things like that in the late 1950s and 1960s, which is great to read, but people don't want to know that anymore. They just want trials. But not only that, we've also forgotten the trials, because a lot of this stuff has been done in the past. There was a trial many years ago of giving babies after cesarean section what they called a bunny hug, of actually giving them a good squeeze. It was a squeeze in the thorax rather than elevating the diaphragm. So it was fairly ineffective and tended to cause more damage. So that was sort of abandoned. The other thing we used to do, well, some people used to do years ago, was the old frog breathing, which is exactly that, knees on the chest and get the baby breathing that way. And that was thought to be ineffective and didn't happen. And the other one, I guess, that we've always known about is that the lungs are a negative pressure designed system, and they should be negatively pressure ventilated, but we've never been able to do it. And I'm just trying to remember the name. I think it was Southgate at Brompton? About 40 years ago, spent a whole lot of time looking at an iron lung type ventilator for the neonate. We'd ventilated the lungs perfectly, but the biggest problem is actually getting a seal around the baby's neck, which caused bleeds and all sorts of problems that way. So that was abandoned as well. So, it sounds like we're coming full circle.
Yes. Well, I think there's just a slight difference, is that, they were trying to use subatmospheric pressures to ventilate the baby, whereas this is more of design, not to move air, but just to stabilize the chest wall. And I think, that therein lies a difference. And it may make it easier, because we're only talking about small pressures, only 6 centimeters of water. We're only talking to, it'll be much easier to, develop a jacket or whatever it is. Well, I don't know how it could be done, but there's lots of smart people out there who I'm sure could come up with an idea where you can achieve the same effect without those issues that you're talking about. Yeah, because the babies used to get cold.
Well, everything in the past involved a seal around the neck, which was the biggest problem.
Yeah.
Well, I guess, the essence of the chest wall determining what happens inside is, of course, with intact pleura only, and the negative sort of suction, which is sort of associated with it. And I think that's really important, for instance, if we have pneumothoraces. There's a couple of questions which are related to, does this everything also apply to the preterm infant, or they just don't have that much fluid to be concerned about?
Look, that's a really, really good question. And when we actually know the preterm infant is not nowhere near as susceptible to the term infant. And the reason is really quite simple, is that as you go from a preterm to a term infant, the air tissue to the airspace to tissue space volume of the lung. So if you look at the lung as a whole, what's the proportion that's airway and what's the proportion that's tissue? Well, in a very immature lung, it's predominantly tissue. And so, you know, in a very immature lung, it might be, say, 60% airspace, 40% tissue. But when you get up to near term, it's more like 80% airspace and 20% tissue. And so since the liquid is all filled, it fills the airways, so you've got a greater volume going into a relatively smaller tissue space in the mature lung. Whereas in the immature lung, you've got a relatively smaller liquid volume going into a relatively larger tissue space. So they don't have anywhere near the same sort of problems. And we've actually measured and published this. It's almost indistinguishable, the effect of having that volume in a preterm, very immature lung.
All right. There's a question here which I think relates to, particularly in the, say, 36 week and 37 weeker. How do we differentiate between RDS and this wet lung? And is there a role for surfactant?
Well, I would argue that it all starts with wet lung. Now, I know people are going to shake their head and say, no, because, you know, we know that steroids work and we know or have an effect here. But if you think about it, you know, because you look at those flux rates that I calculated, 32 litres per kilogram per hour. Okay, that's enormous. And at that sort of rate, that's kidney flux rates. But of course, the kidney deals with that by having a fenestrated epithelium. But the lung has a very tight epithelium. And so moving that volume of liquid backwards and forwards across the epithelium has to cause damage. We think inherently that airway liquid clearance is injurious to the lung. And, you know, if you haven't got much liquid, when you get very little, indistinguishable amount of injury that, you know, has no consequence whatsoever. But I think this process, this wet lung, is actually not only causing all of the respiratory problems, but it's also injuring the lung, which then you develop into a protracted respiratory distress. So at the moment, we really don't know, but my best guess would that we're starting with the same issue. It's just that we're getting to different endpoints. One, because you're getting injury in the lung, and presumably that's going to be the main benefit of CPAP, is to stop that. And that's probably the reason why CPAP is by far the best treatment that we have at the moment.
All right. Time for one more last question. When we started this conversation, you talked about the imaging and how far we have come, you know, to do this kind of imaging. On the other end, we have the involvement of lung ultrasound. Is there a role? Is it differentiating enough, or should we go to what's the progress of the images you have on your rabbits that we have it as clinicians?
It's a really good question. I think, well, for a start, I'm a huge fan of ultrasound, lung ultrasound. I think that it is really good at picking up these issues. It's the penetration that is, you know, I guess the main issue. And in that instance, you just can't get past X-rays. X-rays have the penetration power, and ideally, I would say within 10 years, we will have at least a prototype of a phase contrast X-ray imaging machine that will give you 3D images of the lung at the same dose as what a projection image will give you. And you know, that's state of the art, and it's really high tech, but we've already got to the point where we can do full CTs of the lung using with really high resolution, so we can see alveoli down to that sort of level, which is only the same dose as what you would use on a 2D projection X-ray. So we can already do that. It's just getting the type of X-rays that we need to be able to do it and replicate it in a clinical machine.
And that's it, isn't it? We need these tools first to be used in, you know, physiology research, then into clinical research, and then to become a clinical tool. And you know, I hope I can see it in my time, but we'll see. Stuart, I want to thank you so much. This was a fantastic overview again over a disease which, you know, I put on CPAP and they're better, but how does it work? And I really think you gave us a lot of food for thought and thinking about these kind of cases with way more interest. And back to our physiology book, never sort of apologize for bringing us back. Please do it more. We'll definitely get you back next year. Thanks everybody for attending. Next week is Dr. Gabriel Eltit from Montreal, Canada, who's going to give us an update on the congenital diaphragmatic hernia guideline and how their teams have improved outcomes in these particular babies by spending a lot of attention to the physiology and the development after diaphragmatic hernia and lung and heart development. I hope to see you all next week. Thanks everybody. Thanks Stuart.
Thanks Kurt. It's a pleasure.